Kiran sir, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's session is the diagnosis of HIV infection in adults and children and the assessment of adults and adolescents with HIV infection. Please note, we are conducting region-wise sessions, so this session is for the West region. Today's speaker is Dr. Sachin Dhande. Dr. Sachin Dhande is currently working as a consultant with iTech India. He has completed his Masters of Public Health in Epidemiology and Health Systems from the National Institute of Epidemiology, Chennai. He was associated as a technical specialist, CST, with iTech India, and has also served as a research scientist in National AIDS Research Institute and as a medical manager in Sathi. We welcome you, sir, for today's session and request you to start the session.
Good afternoon, all. Welcome to iTech India National Distance Learning Seminar Series. So this RDLS series will be for National Guidelines for HIV Care and Treatment 2021. Today's topics are diagnosis of HIV infection in adults and children and assessment of adults and adolescents with HIV infection. So we'll start with chapter 1.2, diagnosis of HIV infection in adult and children. So in the diagnosis, HIV is now considered a chronic manageable disease, and majority of the PLHIV remain healthy if correct and timely treatment is started. Late diagnosis is an important factor associated with HIV-related morbidity and mortality. Voluntary HIV testing with informed consent should be offered and encouraged. Previously, there were two types of testing centers. First was VCTC, that is Voluntary Counseling and Testing Center, and another was PPTCT. So both were integrated, and it is called now Integrated Counseling and Testing Services, Testing Centers. So in these ICTCs, the patients were screened and confirmed for HIV diagnosis with three different types of tests. HIV infection is in any individual beyond 18 months of age can be detected by lab test that demonstrates either virus, viral products like DNA, RNA, or antibodies to the virus in the blood or serum or plasma. In children below 18 months of age, due to persistence of maternal antibodies, the antibodies from who is the mother who is HIV positive, her antibodies are perinatally transferred or passively transmitted to the baby. Hence, due to the persistence of maternal antibodies, diagnosis of HIV made by qualitative polymerase chain reaction, PCR test that detects HIV nucleic acids, DNA, and RNA. HIV diagnosis under National AIDS Control Program. Rapid test based on the principles of enzyme immunoassay, immunochromatography, immunoconcentration, dot blot assays, and particle agglutination are used. This rapid currently NACO is using 4th generation rapid HIV testing kits, and those kits can detect P24 antigen. Hence, the test can be positive after 15 days of exposure. Previously for antibodies, so all you know the window period. The window period represents the period between infection with HIV and the time when HIV antibodies can be detected in the blood. It is around 6 to 12 weeks. When the antibodies are developed in the body and then detected in the blood and then detected in this test, rapid test. But due to P24, this test can be positive after 15 days. All these rapid test kits should have a sensitivity of more than 99.5% and specificity of 98%. A blood test performed during the window period may yield a negative test result for HIV antibodies. These cases may require further testing after 12 weeks. Then we will go see for the diagnosis of HIV in adults and children more than 18 months of age. In view of low prevalence of HIV in India, it is necessary to use three different principles or antigen-based rapid tests to confirm the diagnosis. Screening is done at facility ICTC centers or standalone ICTC centers or other centers. So after screening for the confirmation, the sample is patient or sample is referred to the ICT center for the confirmation, standalone ICTCs. In ICTCs, standalone ICTCs, all samples reactive in the for confirmation, second and third test based on different principles and antigens using the same serum or plasma sample as that of the first test. So 3 tests are for the confirmation, 3 tests are done. The same blood sample is utilized for performing all the tests for identifying HIV antibodies. For indeterminate results, testing should be repeated on second sample taken after 14 to 28 days. For diagnosis of clinically asymptomatic individuals who have screened positive or who have been screened, assay 1. See here is the A1 is the assay 1. This test is done. If assay 1 is reported negative, then the patient's report is negative or client's report is negative. If A1 is positive, then assay 2 is done. Second test with different antigen, different rapid test, different principles test is used. Second test is done. If we will see the left side of this PPT. So if A2 is also positive, the A1 positive plus A2 positive, then third test is conducted. So if in third test, if A1 is positive, A2 is positive, A3 is positive, then the report positive is confirmed and the post-testing is done and the patient is referred to ART center for further management. If in the second column, if A1 is positive, A2 is positive, and A3 is negative, then this result is interpreted as indeterminate. Now, in assay 2, if A1 is positive and A1, A2 is negative, then A3 is done. Here also, if A1 is positive, A2 is negative, and A3 is positive, then it is interpreted as indeterminate. And if A1 is positive, A2 negative, A3 negative. If the client is identified from key population like FSW or MSM or having high risk behavior, then as a high risk, the test is interpreted as indeterminate and test is repeated after 14 to 28 days. So if A1 is positive, A2 negative, A3 negative, in high risk group, it is intermediate, but in low risk group, it is considered as negative. This all HIV testing should be provided following 5 essential C's. First, informed consent. Second, confidentiality. Third, counseling. 4, correct test results and immediate connection linkages to services for HIV prevention, treatment, and care. Diagnosis of HIV infection in infants and children less than 18 months of age. As discussed earlier, maternal antibodies to HIV usually persist for nearly 9 to 12 months in the infant. Children born to HIV infected mothers will test positive for HIV antibodies by ELISA or rapid test, regardless of their own infection status, whether it is positive or negative. Hence, NACO recommended the use of total nucleic acid PCR test, TNA PCR, on dried blood spot of the infant to detect viral nucleic acid for diagnosis of HIV-1 infection during infancy. So in total nucleic acid PCR, both DNA and RNA can be detected. This test is performed at 6 weeks of age or at the earliest opportunity when the infant and the mother come in contact with healthcare system workers. At and after 6 months of age, DNA PCR must be performed after screening for HIV antibodies. After 6 months, if antibody is positive, then DNA PCR test is done. Breastfeeding children are tested DNA PCR 3 months after complete cessation of breastfeeding or 18 months of age, whichever is later, to reliably exclude HIV infection. So there are different strategies for the testing for infants. It is DNA PCR, and for the people who have age more than 18 months, then there is antibody rapid test. Now we will go to classification of HIV. There are two types of HIV: HIV type 1 and HIV type 2. The most common cause of HIV infection throughout the world is HIV-1, that comprises of several subtypes with different geographical distributions. In HIV-2, there has 5 subtypes, A to E. In HIV-1, which is common, there are 3 types: M, N, and O. Major. M major, this group is responsible for the HIV epidemic. Nearly 90% of all HIV-1 cases stem from this group. The group has 9 names. The group has 9 9 strains: A, B, C, D, F, G, H, J, and K. Then second is N, new. This form of virus has only been seen in small group of people in Cameroon. And third is outlier group, O. This group has almost as many variations as the M group. However, researchers haven't identified its separate strains yet because it's so rare. So in HIV-1, there is in India, the most common is M. HIV-1 is common. In HIV-1, M is common, and M there is clade C. So in India, most of the patients are having HIV-1 with M type with clade C subtype. So guidance for HIV-2. Natural history studies indicate that HIV-2 is less pathogenic than HIV-1. Those infected with HIV-2 have slower disease progression, a much longer asymptomatic stage, slower declining CD4 count, low rates of vertical transmission, and lower viral loads while asymptomatic, and smaller gains in CD4 count in response to ART. So HIV-2 has slow disease progression, but smaller gains in CD4 count in response to ART. Although HIV-1 and HIV-2 are related, there are important structural differences between them. Accurate diagnosis and differentiation of HIV-1 and HIV-2 is crucial for treatment initiation and in the assessment of treatment failure. Previously, in the ART regimen, backbone is NRTIs and the anchor was NNRTI. So NNRTI were not working on HIV-2. So the treatment is different for HIV-1 and HIV-2 previously. Since DTG is now recommended as the preferred drug for all lines of treatment of HIV infection, it is expected that patients with HIV-2 infection will benefit. For this reason, the HIV-2 diagnosis strategy is different. Clients or client PLHIV refer to nearest ART center with ICTC report. If the report, as said earlier, the rapid kits detects both HIV-1 and HIV-2 infection. If in rapid screening test or the confirmation HIV-2 is detected, then patient is referred to ART center with ICTC report. If the sample found as only HIV-2 reactive by 2 differentiating testing kits at ICTC, then it is reported as HIV-2 reactive and no further testing required and ART started. In second, sample found as HIV-1 plus HIV-2 reactive at ICTC, then sample should be sent to the designated HIV-2 referral laboratory for confirmation. In third scenario, sample found as HIV-2 reactive by only one testing kit at ICTC, HIV-1 by 3 kits and HIV-2 by 1 kit. Then it should be confirmed by HIV-2 referral laboratory. This is the flow chart of referring patient for HIV-2 testing from ART center to reference laboratory. Clients or patients with ICTC reports, specimen is positive for HIV antibodies, HIV-1 and HIV-2 or HIV-2 in one test only and referrals at the ART center. Then ART center refer these patients to designated HIV-2 referral laboratory where sample is collected and tested as per national algorithm for HIV-2 zero diagnosis, reporting to referring ART center both hard copy and soft copy, and retaining a copy of report at ART and hand over original report to patient. So in two scenarios, if the sample found as HIV-1 plus HIV-2 reactive at ICTC, then the sample should be sent to designated HIV-2 referral laboratory for confirmation. The second scenario is sample found as HIV-2 reactive by only one testing kit at ICTC. In this scenario, the HIV-1 is reactive for all 3 tests, but HIV-2 is reactive for only one testing kit. This should be confirmed by HIV-2 referral laboratory in these 2 scenarios. So this was about the diagnosis of HIV infection in adults and children. In adults or adolescents or whose age is more than 18 years, rapid test kits are used for antibody testing. If the age is less than 18 years, then DNA PCR test is done. All these test kits for adults and adolescents can detect HIV-1 and HIV-2. If HIV-2 is positive with 2 testing kits, then it is reported as HIV-2 positive. But if HIV-1 and HIV-2 both are positive, then refer to the designated laboratory for confirmation. If HIV-2 is positive in only by one testing kit, then it referred for the confirmation to the designated laboratories. Now we will see the assessment of adults in adolescents with HIV infection. In the ICTC center, after 3 tests, the result is confirmed as HIV positive, and those patients are referred or linked to the ART center, where those patients are registered and ART is initiated as soon as possible. When the patient comes to ART center, then initial evaluation of PLHIV is done. The first step is clinical assessment and medical history. Second, physical examination. And third, baseline laboratory evaluation. In clinical assessment and medical history and physical examination, the doctors, medical officers can find any OI or any abnormality or find another things. So we will first see a clinical assessment and medical history. First is to determine the clinical stage of HIV infection. By WHO HIV or WHO clinical staging. There are 4 stages. Stage 1 is for patients who are asymptomatic. Stage 2, mildly symptomatic stage. Stage 3, as disease progresses, additional clinical manifestation may appear. So this is the moderately symptomatic stage. And stage 4, the WHO clinical stage 4 for severely symptomatic stage, and designated includes all the AIDS defining illnesses. So at first determine the clinical stage of HIV infection to follow this patient for this staging. Identify the current HIV related illnesses that may require treatment, identify HIV-related illnesses means the opportunistic infections like TB or herpes zoster or candidiasis and other opportunistic infections. Identify any prior exposure to ARVs in the past. This is for the pregnant woman who is HIV positive, who previously exposed to PPTCT, or many people who are in high-risk group use pre-exposure prophylaxis. So identify any prior exposure to ARVs in the past. Determine the need for OI prophylaxis. If the patient's CD4 count is less than 350, then co-triamoxazole prevention prophylaxis therapy is given, CPT is given. Identify coexisting medical conditions such as diabetes, hypertension, hepatitis, or any other treatment that may influence the choice of ARV drugs. Determine nutritional status and needs. Elicit the history of past illnesses, especially TB and STIs. Elicit HIV status of family members, partners. Offer index testing services for spouse or sexual or injecting partners, and offer testing for biological children. Assess the need for psychosocial support because the patient is newly diagnosed as HIV positive. He may be depressed, maybe have suicidal tendencies, acceptance issues, disclosure issues. So psychosocial support to be given. In medical history, first, the HIV testing. Second, most important, for every visit, four symptom screening for TB is done. Screening is done. For this screening. In adults, it is fever. First is fever, second cough, third weight loss, fourth night sweats. In children, fever and cough is common, but instead of weight loss, in children, poor weight gain, reported weight loss, and instead of night sweats, history of contact with TB case. For first visit to every follow-up visit, forest screening is done for all PLHIV who is not on TB treatment. Any persistent symptoms like headache, poor concentration, seizures, diabetes, hypertension, or other NCDs, history of tuberculosis in past prior exposure to ARVs as already discussed, history of STI, HIV risk behavior, substance abuse like alcohol, tobacco, oral and injecting drugs may hamper the adherence of ART, then pregnancy and contraception for PPTCT, prevention of parent-to-child transmission of HIV and syphilis, then allergies to any medications, nutritional status, and psychosocial assessment. This medical history checklist is given in our technical guidelines. There are few points like HIV testing, ever tested for HIV in the past, then date of HIV testing, reason for HIV testing, report of HIV testing, previous CD4 cell count or previous viral. If already patient taking ART from private sector, private hospitals, then we can get his ART regimen details, his previous viral load, previous CD4 counts. Also ask for HIV risk. This can be multiple like unprotected sexual contact, drug use, CSW, MSM, occupational exposure, perinatal transmission. Then review of clinical symptoms. As discussed, forest screening. In forest screening, unexplained weight loss, night sweats, fever, cough, fever with chills, change in appetite, skin rash, abdominal pain, vomiting, diarrhea, partial loss of vision, visual field defects. For this, past history of HIV-related illnesses, past history of opportunistic infections. Most common is tuberculosis, herpes zoster, cryptomeningitis, oral esophageal candidiasis, varicella zoster, toxoplasmosis. So this checklist is provided in technical guidelines, and as per this checklist, this history is to be, medical history is to be taken. Tuberculosis history. In tuberculosis history, history of past TB infection, then treatment given, which drugs were given, and the duration of treatment of AKT, history of TB in family or close contacts, then ART history. In ART history, current and past exposure to ARV. This may be from PPTCT. Second is pre-exposure prophylaxis, and third is post-exposure prophylaxis. So thorough current and past exposure to ARV history to be taken. ARV use during pregnancy for PPTCT, post-exposure prophylaxis, pre-exposure prophylaxis, drugs taken, and for how long. If already positive, then ART is taken or not. If taken, for how long, which regimen. Then partner ART history, if partner is positive, is he taking or is she taking ART? Then STI, substance abuse, general medical history, allergies, medication, other medications. If medication, then vaccination history, gynecological history, pregnancy and contraception history, previous pregnancies, children and HIV status of the children, exposure to ARV during pregnancy, drugs and duration of ART, contraception, last menstrual period, psychosocial history, and functional status. These all are given in medical history checklist in technical guidelines. So this checklist referred for the assessment of adults and adolescents with HIV infection for medical history. Second is physical examination. General examination like temperature, pulse rate, blood pressure, respiratory rate, body weight, height, pallor, icterus, cyanosis, clubbing is looked for the dangerous sign. Then examination of lymph nodes for diagnosis of TB, mouth and oral cavity examination to find out if there are any candidiasis or other fungal infection in oral cavity and mouth, examination of skin, and look for the sexually transmitted infection, STIs. And last is system examination as indicated, respiratory, perabdominal, neurological, and cardiovascular. So there are WHO clinical staging. In WHO clinical staging, there are 4 stages. Stage 1 for asymptomatic, stage 2 for mildly symptomatic, stage 3 for moderately symptomatic, and 4th is for AIDS-defining illnesses, severely symptomatic stages. So in WHO clinical stage 1, the patients are asymptomatic or having persistent generalized lymphadenopathy, painless enlarged lymph nodes of more than 1 centimeter in 2 or more non-contagious sites in the absence of known cause and persisting for 3 months. So in clinical staging, 1, asymptomatic and persistent generalized lymphadenopathy. In clinical staging 2, this is mildly symptomatic, moderate unexplained weight loss less than 10% of presumed or measured body weight. So in the left side of the table, adults, and the right side, there are diseases for children. So in adults, moderate weight loss, less than 10% of measured body weight, herpes zoster, fungal nail infections, and in children, unexplained persistent hepatosplenomegaly, extensive wart virus infection, extensive molluscum contagiosum, recurrent oral ulceration, herpes zoster. These are the common in clinical stage 2. For clinical staging 3, unexplained severe weight loss in adults, unexplained severe weight loss, then diarrhea for longer than 1 month, severe bacterial infections, and pulmonary tuberculosis are common. Persistent oral candidiasis is also common. In children, unexplained moderate malnutrition, unexplained persistent diarrhea for more than 14 days. So in adults, persistent diarrhea for more than 1 month. In children, it is persistent diarrhea for 14 days, more days or more. Unexplained persistent fever for longer than 1 month, lymph node tuberculosis, and pulmonary tuberculosis. So these are common in clinical staging 3. Unexplained anemia, neutropenia, and chronic thrombocytopenia is common in clinical staging 3 in both adults and children. Clinical staging 4. So these are the AIDS defining conditions. HIV wasting syndrome, severe weight loss in adults, PCP pneumonia, recurrent severe bacterial pneumonia, chronic herpes simplex, esophageal candidiasis, all extrapulmonary TBs, cytomegalovirus infection, CNS toxoplasmosis, HIV encephalopathy, lymphoma, recurrent septicemia, invasive cervical carcinoma. So these are clinical staging 4 in most common in clinical staging 4 in adults. In children, unexplaining severe wasting, stenting, severe malnutrition, not responding to standard therapy, PCP pneumonia, recurrent severe bacterial infections, chronic herpes simplex infection, esophageal candidiasis, and all extrapulmonary tuberculosis in children, cytomegalovirus, CNS toxoplasmosis. So these are the clinical staging and the diseases or infections. So let's have some questions. You can type in the chat box. We have some photographs. After these photographs, you can type your answer in the chat box. Please use your chat box for the responses. So what is the clinical staging of OI in the picture? You can also type the infection. Yes, it is herpes simplex and stage 2. Thank you. Second photograph. Stage 2 herpes zoster. Yes, candidiasis. This is also candidiasis. We have to evaluate if it is esophageal or not. And this may be persistent generalized lymphadenopathy or extrapulmonary tuberculosis of lymph nodes. Thank you for your responses. So signs of serious illness. So on examination, if the PLHIV present with any of the following signs of serious illness, then immediate referral for expert evaluation is must. So if the patient has serious illnesses, may have a severe infections. So which are the signs of serious illnesses? First is temperature more than 39 degrees Celsius with headache, maybe meningitis, respiratory rate more than 30, heart rate more than 120 per minute, SpO2 less than 90, altered mental status, confusion or strange behavior or reduced consciousness. Then other neurological problems such as persistent severe headache, seizures, paralysis, difficulty in talking, rapid deterioration of vision, or unable to walk unaided. Any other condition that requires emergency management are referred to experts for their evaluation. After signs of serious illness, if we have to check if the patient is having advanced HIV disease or not. The definition of advanced HIV disease is for adults and adolescents and children older than 5 years, CD4 count less than 200 or WHO stage 3 and 4. This includes both ART naive and those who interrupt treatment and return to care. So all PLHIV whose CD4 count is less than 200 or WHO stage 3 or 4 are defined as advanced HIV disease, is having advanced HIV disease. And in CLHIV, newly diagnosed CLHIV age less than 5 years, severe immune suppression following treatment failure, and re-engaging with the care after treatment interruptions. So all CLHIV who are newly diagnosed and age less than 5 years, all CLHIV with severe immune suppression following treatment failure and re-engaging with the care after treatment interruption. Children older than 2 years of age who have been receiving ART for more than 1 year are established on ART and are clinically stable should not be considered to have advanced disease. So children whose age is more than 2 years receiving ART for more than 1 year on ART and are clinically stable should not be considered to have advanced disease. So as per definition, all PLHIV whose age is more than 5 years, advanced HIV disease defined as CD4 count less than 200 or WHO stage 3 or 4. So as per WHO, the package special advanced disease management package is given. The first in the package, the first is TB screening through LAMP urine test or TB screening. Second, screening for cryptococcus. Third, if patient is not on ART, newly diagnosed, then rapid ART initiation. Fourth, if patient CD4 count is less than 350, then CPT, co-trimoxazole prophylaxis therapy. And fifth, monitoring adherence. So in advanced HIV disease, the most common cause of mortality is cryptococcus and tuberculosis. So screening of these two diseases. Third, rapid ART initiation, prophylaxis, CPT and IPT, and monitoring of adherence. So this package is given in advanced HIV disease. Nutritional assessment. So we have a separate topic or session on nutritional assessment later. So in this slide, BMI less than 18.5 kilogram is recognized independent risk factor for morbidity and mortality in HIV positive adolescents and adults. So this nutritional assessment should include following. First is anthropometric measurements, assessment of edema. Bilateral edema is sign of severe malnutrition, but edema in adults can be caused by other pathologies also, like renal, cardiac, or hepatic issues. So this must be checked and ruled out for before deciding that the edema is being caused by malnutrition. And third, dietary and food history. This is important to modify the dietary requirements if PLHIV are deficient as per the recommended needs. If the HP is low or maybe protein deficiency, then the dietary requirements are modified. So we saw medical history, physical examination, and the third is comprehensive laboratory evaluation. So these baseline investigations are essential tests for patients registering in HIV care at ART centers. First is CBC, second urine, routine and microscopic, third fasting blood sugar, then serum creatinine, blood urea. Serum creatinine is important because we are initiating PLHIV on tenofovir-based regimens. Then serum bilirubin, ALT, VDRL, CD4 count, and X-ray chest PA view. Non-availability or non-feasibility of any of these tests should not delay the initiation of ART. So these are the baseline investigations, and these are some additional tests at baseline as per the physician decisions. Symptoms and signs directed investigation for ruling out OIs, including MTB by sputum through Sebinet test, complete liver function test LFTs for those being initiated on ATT and for patients with hepatitis B or C co-infection, lipid profile, USG abdomen. Then in Bihar, Uttar Pradesh, Jharkhand, West Bengal, the RK39 strip test to confirm or rule out leishmanias, pregnancy test if applicable, cervical pap smear, and for MSM, anal pap smear. Important is non-availability or non-feasibility of any of the tests should not delay the initiation of ART. And for this baseline investigation, please follow the rapid ART initiation, which is given in technical guidelines. This is the assessment and management of the patient at first visit. What should be done on the first visit? First is registered in HIV care registration. Pre-ART number is given. Before registration, the report should be or must be from the SAICTC, the confirmed report with valid PID number. Second, as we discussed, medical history. Follow symptom screening checklist. Forest symptoms for TB screening at every visit. physical examination, psychosocial assessment, education level, employment, financial. So all this included in the white card. So education level, employment, financial resources, family household structure, disclosure status, understanding of HIV/AIDS transmission, risk reduction, treatment options, nutritional status, then family household assessment to determine if there are other HIV infected family members who may need care, ART initiation. All biological children's spouse are tested for HIV. Recommend condom use during every visit. Baseline investigations, essential tests including CD4 count and additional tests as per required. If CD4 count is less than 350, initiate co-triamoxazole prevention therapy and commence ART if the patient is adequately prepared. ART to be dispensed for 1 month and concurrently send samples for CD4 count and other baseline investigation as per NACO guidelines. Refer rapid ART initiation in chapter 2.2. Before follow-up visits. So as per protocol, rapid ART initiation protocol, review test result. If test reports are normal, PLHIV to be called back to ART center as soon as possible within 2 weeks of ART initiation. So here we said in the last sentence, patient is adequately prepared for ART and then ART to be dispensed for 1 month and concurrently samples are sent for testing for CD4 count and other baseline investigation as per NACO guidelines. If the test reports came abnormal, then PLH would be called back to ART center as soon as possible within 2 weeks of ART initiation. And ART counselor to call all patients to learn about general well-being of patients within 2 weeks of ART initiation for general well-being, for adherence, for any side effects or any new OI. The ART counselor to call the patients who are newly initiated on ART within 2 weeks of ART initiation. And for subsequent follow-up visits after initiating ART, history, any new problem, any new OI, then symptom checklist, clinical examination, for a symptom at every visit, note any side effects like insomnia, anemia, rash, fever, signs of hepatotoxicity, nephrotoxicity, investigation as per monitoring and follow-up related to ARV, counseling, adherence assessment, and support. So for the assessment, the first is medical examination, then physical examination. Third is lab testings we discussed. So clinical assessment, physical examination, and baseline lab evaluation. For clinical assessment, the checklist is given in the guidelines. Physical examination done, and then baseline. For baseline testing, there are essential tests and some additional tests. So like this, assessment of adults and adolescents with HIV is done. If any questions, please type in the chat box.
Thank you so much, sir. Participants can either type in the chat box, the questions in the chat box, or they can ask questions. You can unmute your mic now. Any questions on diagnosis and assessment? Sir, I don't think there are any questions. Thank you for facilitating this session. Thank you to all the participants for patient listening. Participants to kindly note that the next session will be held on 22nd. This is the wrong date. Please give me 2 minutes. Yeah, the next session will be held on next Thursday. That's 23rd of December. And the session title is ART in Adults and Adolescents and Adherence to ART. Kindly note all the senior medical officers and the medical officers of the ART center are requested to please fill in the post-test form that will be sent with the recorded link. We'll send it by tomorrow evening. So when the ART sees, please ensure that the senior medical officers or the medical officers are filling that form. We can conclude the session now, sir.
Yes.
Yeah, thank you, sir.